Welcome to this AJNR podcast article summary. I'm your host, Francis Deng. I'm here to discuss a recent study from our colleagues at Cooper University that was an editor's choice article in December. The first author is Jessica Vankawala, a fourth-year medical student at Cooper Medical School, and the senior author is Hamza Sheikh, a neurointerventionalist and associate professor of neurosurgery and radiology at Cooper. Before we dive into the findings, I want to introduce you to the Biffl scale, also known as the Denver grading system. This is a grading system initially developed in the late 90s by Walter Biffl, a trauma surgeon then at Denver Health Medical Center, for classifying blunt carotid injuries on imaging, and then it was also applied to vertebral artery injuries. I use this scale routinely when reporting abnormal neck CTAs obtained in trauma patients. And the scale is well known to trauma surgeons, neurosurgeons, and neurologists, so it behooves neuroradiologists to know it as well for optimal communication. For the video viewers of this podcast, you can follow along these figures that are taken from a prior review article published in the AJNR in 2018 by Prashant Nagpal and colleagues then at the University of Iowa. So grade 1 blunt cerebrovascular injury, or BCVI, as I'm going to say, are wall abnormalities that cause less than 25% luminal narrowing, and that can appear as irregularity of the wall, a raised interval flap, or wall thickening due to intramural hematoma. The key here is in grade 1 BCVI, there is less than 25% luminal narrowing. When there is minimal irregularity without a raised intimal flap and without a crescentic wall thickening, the CTA findings of grade 1 BCVI are similar to that of fibromuscular dysplasia, or FMD. Both blunt injury and FMD tend to affect the distal cervical segments of the internal carotid and vertebral arteries. The trauma context is important to remembering to include BCVI grade 1 in the interpretation if you see irregularities like this. If you have pre-trauma imaging to establish stability, then you can say it's FMD. But if you do not, as we often don't, then I say it may represent either grade 1 BCVI or FMD. If the finding on follow-up CTA, usually performed weeks to months later, is unchanged, then FMD is more likely, as that is a relatively more static disease than the dynamic nature of BCVI. If it gets worse or better, then a dissection or intramural hematoma is more likely. Grade 2 BCVI is greater than or equal to 25% luminal narrowing due to dissection with a raised intimal flap or intramural hematoma. Or alternatively, grade 2 BCVI includes free-floating intraluminal thrombus. Sometimes it can be difficult to distinguish luminal narrowing from chronic atherosclerosis versus intramural hematoma, so the context, of course, is again important. In the trauma setting, and especially if you have a cervical spine injury like a fracture or facet dislocation, as we see in this image, you can be confident calling this a BCVI. And another mimic is a hypoplastic vertebral artery, but that should be very long segment, small caliber vessel, and the surrounding foramen transversarium is small as well. Grade 3 BCVI is a pseudoaneurysm. That is, this is a saccular outpouching. The contours are wider than the normal vessel lumen, and this represents essentially a contained rupture as the blood and the contrast has extended beyond the confines of the intima, the media, and the adventitia. Grade 4 is occlusion. In the vertebral arteries, the occlusion appears as an abrupt cutoff, usually, as there are many potential levels of collateral flow from small branches above and below the injured level to maintain contrast opacification, whereas in the carotid it is more common to have a tapered narrowing as the internal carotid artery in the cervical segment does not have any branches. Now finally, grade 5 is transection with free extravasation. That is visible as a leakage of contrast around the artery. And a mimic would be venous enhancement in the vertebral artery venous plexus, either due to arteriovenous fistula, venous phase contamination, or reflux from the IV injection of that contrast. So make sure that the contrast that you see extends beyond that area immediately around the artery, and look for other venous structures to determine the right contrast phase your images are in. And consider incorporating a delayed phase to your next CTA protocol, especially if you have a patient that has suspected active bleeding or hematoma in the neck. The image that we see here are bilateral vertebral artery injuries transection with free extravasation. So you may encounter a trauma patient with a cervical spine fracture and CTA reveals what looks like a vertebral artery injury. So we're getting back to the paper at hand currently here in the AJNR. The patient seems fine neurologically, no acute stroke, but here's the dilemma. Should we anticoagulate, observe, intervene? And the answer hinges on predicting who will have a stroke. And for years, the Biffl grade has been our workhorse for this decision-making. And the logic is pretty intuitive that the higher grade injuries look worse on imaging, so they should carry a higher stroke risk. But does this assumption actually hold for the vertebral arteries? And that is what Vankawala and co-authors asked. But before we get to our study, let me talk about what was known before. In 2024, published in the Journal of Neurosurgery, was a systematic review and meta-analysis of 56 studies on vertebral artery injury after blunt trauma, and this is by Vankawala and colleagues at the Mayo Clinic. The senior author is Mohammed Biden, a spine surgeon who is now at the University of Chicago. In that meta-analysis, the prevalence of vertebral artery injury was 0.5% out of blunt trauma cases overall. It was 3.8% of cases that had cervical spine fracture or ligamentous injury detected on CT. And vertebral artery injury represented 14.5% of cases that were screened with vascular imaging, either CTA, MRA, or DSA, because the case met some high-risk screening criteria at the time. And so this is a pretty non-trivial amount. It's relatively common. And in a meta-analysis of 35 studies performed in this paper that included 1,668 patients, the risk of stroke in patients with vertebral artery injury was estimated at 5.3%, 95% confidence interval of 3.5 to 8.0%. And the stroke rate varied among different Biffl grades or Denver grades. In this meta-analysis, including 660 patients, the stroke risk in grade 1 vertebral artery injury was 1.9%. For grade 2, it was 3.0%. For grade 3, it was 9.8%, and for grade 4, it was 10.9%. They didn't have enough grade 5 cases to analyze. The confidence intervals here are a bit wide, but the point estimates of the stroke prevalence did increase monotonically as you increased in Biffl grade, and it was statistically significantly higher for the group of grade 3 and 4 as compared to the group of grade 1 and 2. So this seemed to validate the intuitive notion that the worst-looking injuries on the Biffl scale meant worse outcomes for the vertebral artery injuries. Remember, again, that the Biffl scale was originally developed for carotids, and what we're trying to look at here is whether it also applies for the vertebral arteries. So now back to our main AJNR article by the team at Cooper, by Vankawala and colleagues. Let's see if their findings align with the prior meta-analysis. So these authors did a single-center retrospective review of cases at vertebral artery injury diagnosed on CTA at a level 1 trauma center. There were 219 patients included in their study, diagnosed over the course of 7 years that they looked at. They were all adults. The mechanism was motor vehicle accident in half, and falls were most of the rest. And the V2 segment was the most often involved segment, followed by the V3 segment. And the Biffl grade 1 was the most common grade of injury at 41%, followed by Biffl grade 4 at 33%. So I think this is relatively representative of my experience at trauma centers as well. Most of the patients in this study were treated with antiplatelet therapy, but some were observed, potentially because they had bleeding, contraindication to antiplatelet therapy. Some were also treated with procedural intervention. The primary outcome of this study was stroke within 14 days, which occurred in 10% of patients with vertebral artery injury in this cohort. So this rate is a little bit higher than the Vankawala meta-analysis. Of the patients who had a stroke, most of them had the stroke within the first few days of admission. Biffl grades were determined retrospectively by consensus review of the CTAs by 2 experts trained in either neurosurgery or neuroradiology. In Table 3 of the paper, the authors reported unadjusted odds ratios in univariate analyses, and they found that Biffl grade 2 and 4 injuries had a higher risk of stroke than grade 1. And according to my calculations based on their table, grade 1 was observed to have a 3.4% stroke risk. Grade 2 had a 21.1% stroke risk. Grade 3 was 7.1%. Grade 4 was 12.5%. Grade 5 was 16.7%. Patients with grades 3 and 5 injury in this cohort had only 1 stroke in each group, so the comparison did not reach statistical significance. The authors concluded that the risk of stroke after traumatic vertebral artery injury did not directly correlate with Biffl grade, and suggest further research to identify additional prognostic factors to guide optimal treatment for patients with these injuries. I would close by editorializing that there are some limitations to this study. The number of events in this one study are small, resulting in the wide confidence intervals for the estimate of stroke risk at each Biffl grade. It's possible to state, based on their analysis, that some grades had a higher risk of stroke than grade 1. But in my opinion, it's not possible to say that it's definitive that there's not a monotonic increase in risk with each higher grade, as we know there is with carotid injuries. In my opinion, this study needs to be integrated with the prior meta-analytic studies by Michaelopoulos and others to consider the validity of the Biffl grading scale for traumatic vertebral artery injuries as to their stroke risk. For now, I will continue to use the scale when reporting next CTAs with blunt cerebrovascular injury. And those are my thoughts. I hope you have a chance to check out this article for yourself on the AJNR website. Thanks for listening to this podcast, and I'll see you next time.